attend RSNA 2023, our industry influencers and radiology trailblazers are set to help you embrace what's next in medical imaging. Imagine what new medical imaging practices and technology can teach about collaboration and innovation. We have everything you need, all in one place, as we help you explore how to lead through change. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Early bird pricing is available through October 4th. Register now for the RSNA 2023 at rsna.org/register. Hi, my name is Katie Epstein from Cincinnati Children's Medical Center. Welcome to the RSNA RadioGraphics podcast. I will be talking about a practical approach to Diagnosis of Spinal Dysraphism by Barbara Trapp and colleagues. There is a wide, heterogeneous range of congenital malformation of the spinal cord, which vary in both imaging and clinical characteristics and complexity. They can represent a diagnostic challenge for even the most experienced radiologists. The term spinal dysraphism is an umbrella term used to describe congenital malformations of the spine and spinal cord and are a subtype of neural tube defects. The estimated prevalence of spinal dysraphism is about 1 to 3 per 1,000 live births. Most common site of involvement is in the lumbosacral spine in approximately 90% of cases, followed by the thoracic spine and cervical spine. Knowledge of normal spinal cord embryologic development and key imaging findings of spinal dysraphism is crucial as radiologists play an important role in the diagnosis of congenital spinal malformations. Early detection leads to better patient outcomes and helps guide parental counseling and treatment decisions. Embryologic development of the spinal cord is a complex process that can be broken down into 3 main steps, including gastrulation, primary neurulation, and secondary neurulation. First step, gastrulation, begins between the 2nd and 3rd gestational weeks and ends in the middle of the 3rd gestational week. Gastrulation is the transformation of the bilaminar embryonic disc to the trilaminar embryonic disc through the addition of the mesoderm. The notochord is formed along the midline from the mesodermal cells which migrated between the initial 2 layers, the ectoblast and the hypoblast. This migration of cells between the 2 layers displaces the hypoblast caudally and forms the endoderm. By the middle of the 3rd gestational week, the embryo is composed of a trilaminar disc and fully formed notochord. Next step is primary neurulation, which occurs between the 3rd and 4th gestational weeks. The notochord induces the formation of the neural plate in the dorsal midline of the ectoderm. The neural groove in the center and the 2 neural folds are formed and bend towards one another until they fuse at the midline. The neural tube is subsequently formed in the mesoderm once the neuroectoderm detaches on both sides from the cutaneous ectoderm. This tube then closes in a zipper-like manner bidirectionally. Finally, the cutaneous ectoderm covers the overlying skin. The 3rd and final step is secondary neurulation, in which occurs between the 5th and 6th gestational week. The secondary neural tube, aka the tail bud, is formed caudal to the primary neural tube from a solid mass of cells. The secondary neural tube then merges with the cranial neural tube. Subsequent regression of the tail bud forms the tip of the conus medullaris and filum terminale. Abnormalities in any of these steps can lead to spine or spinal cord malformations. Most resultant abnormalities are secondary to derangement in the primary neurulation stage. How are spinal dysraphisms imaged? Imaging of the spine and associated malformations are best characterized by MRI both pre- and postnatally. MR imaging provides excellent spatial resolution and soft tissue contrast without the use of ionizing radiation. However, it may require sedation to obtain diagnostic images. Postnatal MR protocol should include whole spine T1 and T2 sagittal images and at least 1 panoramic coronal sequence. Imaging the whole spine allows correct vertebral numbering and identification of other associated anomalies. Also, dedicated axial T1 and T2 weighted images at the region of interest are recommended, utilizing 3 mm or less slice thickness. Ultrasound can play a secondary role and is often used initially prenatally during the 20-week gestational age fetal anatomy screening exam. Spine ultrasound is also utilized in neonates, 4 months or younger, before ossification of the posterior elements, typically in those neonates who present clinically with a midline hairy nevus, gluteal dimple, or cleft. This modality is helpful in detecting associated malformations, including genital urinary anomalies. However, ultrasound is not indicated for evaluating open spinal dysraphisms given predisposition to infections. CT has a limited role in evaluation of open spinal dysraphisms given low sensitivity, poor soft tissue contrast, and use of ionizing radiation, although may be used in select cases such as in those with severe vertebral anomalies. Let's first discuss the classification system used. The clinical radiologic classification of spinal dysraphisms is the most used classification. According to the classification, spinal dysraphisms are divided into 2 major groups: open and closed spinal dysraphisms. Open spinal dysraphism is defined as direct exposure of the neural tissue and meninges to the external environment without overlying skin covering. Differential diagnoses in this category include myelomeningocele, myelocele, myeloschisis, and hemimyelomeningocele. All open spinal dysraphisms are considered neurosurgical emergencies. In closed spinal dysraphism, the neural and meningeal tissues are skin-covered and subdivided into 2 groups: those with a subcutaneous mass, including lipomyelocele, myelocystocele, meningocele, and those without a subcutaneous mass. Closed spinal dysraphisms without a subcutaneous mass are further subclassified as simple dysphoric states and complex dysphoric states. Simple dysphoric state differential diagnoses include filar and intradural lipomas, tight filum terminale, and persistence of the terminal ventricle. Complex dysphoric states include dorsal dermal sinus, dystemmatomyelina, caudal regression syndrome, and limited dorsal myeloschisis. Now we will discuss a few of the more common open and closed spinal dysraphisms encountered in clinical practice. Let's start with myelomeningocele, the most common type of open spinal dysraphism. 98% of open spinal dysraphisms are myelomeningoceles, with a prevalence of 0.6 to 1 case per 1,000 live births, and occurs slightly more so in females compared to males. Spinal malformation is thought to occur secondary to a defect in primary neurulation, one of the main 2 theories. 2 main characteristics of myelomeningoceles are exposure of the neural plaque to the environment without overlying skin covering and expansion of the underlying subarachnoid space. Both protrude through the osseous defect, also known as spina bifida, with the neural plaque extending above the skin surface secondary to the dilated subarachnoid space. Postnatal MRI of untreated myelomeningocele is rare, as the diagnosis is usually made prenatally with ultrasound, and fetal MRI is subsequently utilized to further evaluate these fetuses, secondary to higher spatial and contrast resolution. Fetal MRI will demonstrate discontinuity of the skin and subcutaneous tissue with herniation of the neural plaque through the osseous defect, most commonly in the lower lumbar and upper sacral region, rarely in the cervical and upper thoracic spine. Images show expansion of the adjacent subarachnoid space. Neurologic deficits correlate with the affected segment, with lumbosacral being the most common. These patients typically have lower extremity deficits, paraplegia, bowel and bladder incontinence, skeletal deformities such as clubfoot, and hindbrain dysfunction. Myelocele is a rarer subtype of open spinal dysraphism that we will briefly discuss next, where the neural plaque is exposed to the environment, the amniotic fluid, through the osseous defect, although without posterior expansion of the subarachnoid space. There is discontinuity of the skin and subcutaneous tissues like described previously with myelomeningocele, and the plaque is flush with the skin surface, or it also may be depressed, also known as myeloschisis. Key point in open spinal dysraphism is that they are all associated with Chiari-2 malformation, although the severity of the posterior fossa malformation is variable. Main imaging findings include small posterior fossa, slit-like or effaced fourth ventricle, herniation of the hindbrain, enlargement of the supratentorial ventricles, callosal dysgenesis, and tectal beaking. Let's move on to closed spinal dysraphisms, starting with those with a subcutaneous mass. First category we will talk about are lipomas with dural defects, which include lipomyelomeningocele, lipomyelocele, and lipomyeloschisis. These malformations represent a continuum and differ from one another by the position of the cord-lipoma interface, with a prevalence of 16.4% of all closed spinal dysraphisms. Errors in primary neurulation is thought to be the underlying etiology, secondary to early premature separation of the cutaneous ectoderm and the neuroectoderm, which allows mesenchymal tissue into the neural tube and subsequent formation of a lipomatous mass. Clinically, these lesions present with a subcutaneous fatty mass above the intergluteal crease extending into the buttock region asymmetrically. Fat component may grow with age. MRI findings demonstrate intradural lipomatous mass attached to the spinal cord, also known as the cord-lipoma complex. Patients with lipomyelomeningoceles exhibit a low-lying cord-lipoma interface, which is located outside the vertebral canal and usually occurs off midline, with traction of the placode toward the lipoma, and the posterior meningocele is on the other side, opposite to the placode lipoma interface. In comparison to lipomyelocele and lipomyeloschisis, there is no associated meningeal herniation or expansion of the subarachnoid space. The position of the cord-lipoma interface distinguishes the two dysraphisms. Lipomyelocele is situated at the level of the neural arches, versus lipomyeloschisis is within the spinal canal. The following two spinal dysraphisms, lipomyelocele and liposchisis, are often used interchangeably, as the defect may occur over several spinal levels with variable length of the cord-lipoma interface. Next closed spinal dysraphism with a subcutaneous mass we will talk about is meningocele. Embryologic mechanism is uncertain, although thought to be secondary to the failure of separation between the meninges and the cutaneous ectoderm. These lesions represent 2.4% of all closed spinal dysraphisms. On MRI, there is extraspinal hernia of the meninges through the spina bifida defect only containing CSF, and the spinal cord is normal. Final diagnosis in the subcategory of spinal malformations is myelocystocele. These lesions can occur at any level of the spine and are classified into terminal versus non-terminal. Terminal myelocystoceles are located at the lumbosacral region and are more common, 5% of all closed spinal dysraphism. Defect in secondary neurulation is the underlying embryologic etiology, in comparison to non-terminal myelocystocele, which is an anomaly of a primary neurulation and are in the cervical or thoracic region. MRI findings in terminal myelocystoceles include a low-lying hydromelic cord herniated through lumbosacral defect into a skin-covered sac. There is the characteristic trumpet flaring of the distal cord. This anomaly is usually associated with the OEIS complex, which includes omphalocele, exstrophy, which is bladder or cloaca, imperfect anus, and spinal anomalies. Next, we will discuss closed spinal dysraphism associated without a subcutaneous mass, including simple and complex anomalies. Simple dysphoric anomalies we will discuss include both intradural lipoma versus lipoma of phylum terminale. Intradural lipomas entail a wide spectrum of lesions, from cervical to lumbosacral spinal lipomas, which vary in both size and mass effect. Terminal lipomas may extend through an osseous defect. In contrast to lipoma of phylum terminale, or filar lipoma, which is typically a small lipomatous lesion at the phylum terminale region, it is important to remember that this imaging finding can be associated with caudal regression syndrome or tethered cord. This diagnosis should not be confused with fatty phylum terminale, which is a lipomatous infiltration of the phylum with a maximum thickness of 2 millimeters. There is no associated clinical stigmata. Moving on to complex dysphoric anomalies, we will start with dermal sinus tract or dorsal dermal sinus, a closed spinal dysraphism without a subcutaneous mass. Dorsal dermal sinus is a midline fistula that connects the skin surface to the central nervous system and meningeal membranes. Prevalence is estimated at 1 case in 2,500 live births, with the most common site of involvement at the lumbosacral region. Etiology is focal failure of disjunction of the neuroectoderm from the ectoderm, error in primary neurulation. Clinically, an osteum may be observed at midline, and there may be associated capillary angioma, hairy nevus, or hyperpigmented patch. This may lead to several complications including meningitis, infectious versus chemical, abscess, and CSF leak. MRI shows a thin band extending from the subcutaneous tissues or skin surface with oblique trajectory to the spinal canal, best seen in sagittal and axial projections, and can be better detected using either KISS or Fiesta sequences. Dorsal dermal sinus can be associated with dermoid or epidermoid cysts, which can be best detected on DWI, diffusion-weighted imaging. Next complex dysphoric anomaly is diastematомyelia, also referred to as split cord malformation, and accounts for 3.8% of all closed spinal dysraphisms. Diastematomyelia is defined by a division of the spinal cord into two hemichords and is divided into two types, type 1 and type 2. Type 1 diastematomyelia, both hemichords have their individual dural sac and are separated by an osteocartilaginous or bony septum. In comparison to type 2, where there is only a single dural sac containing both hemichords, which may be separated by a fibrous septum. Associated vertebral anomalies are milder versus those seen in type 1. Last complex dysphoric anomaly we will briefly talk about is caudal regression syndrome, also known as caudal regression sequence or sacral agenesis, and consists of a range of abnormalities including lumbosacral agenesis with additional malformations involving the genitourinary, gastrointestinal, and musculoskeletal system. Estimated prevalence is 1.3 cases per 10,000, with increased risk seen in those with diabetic mothers. There are two types of caudal regression syndrome, type 1 and type 2. There are 4 key take-home learning points I hope you can walk away with. Let's summarize them now. Number 1, spinal dysraphisms are a complex group of congenital spinal anomalies that are thought to result from an error in embryology during gastrulation, primary neurulation, or secondary neurulation. Understanding the normal embryological spinal development can help you, the radiologist, better understand how derangements of this normal process leads to each type of spinal dysraphism. Number 2, 2 major groups according to the clinical radiologic classification of spinal dysraphism, which include open and closed spinal dysraphisms. Open dysraphisms do not have a skin covering and hence are exposed to the external environment, the amniotic fluid, and are neurosurgical emergencies, versus closed dysraphisms, where there is an overlying skin and or cutaneous tissue covering the neural and meningeal tissues. Number 3, closed dysraphisms can be further subdivided into spinal anomalies with and without a subcutaneous mass. And finally, number 4, both pre- and postnatal neural imaging is critical in diagnosis, detection of associated anomalies, malformations, therapeutic planning, and parental counseling. Overall, congenital malformations of the spine are best characterized with MRI as it provides both excellent spatial and contrast resolution without the use of ionizing radiation.